Sharon Tucker. I am the Grace Sills Endowed Professor of Psychiatric Mental Health Nursing for the Ohio State College of Nursing. And I'm also the director for the Implementation/Translation Science Core of the Helene Fold Trust National Institute for Evidence-Based Practice in Healthcare. And my experiences have been largely in clinical settings. I've been the director for research and evidence-based practice and quality in two large academic medical centers for about 15 years. And Dr. Melnick recruited me here about a year and a half ago to Ohio State. And since then, I've been privileged to join the fold and to work with a number of other folks across the Ohio State, but also the country, to continue to build our work together around evidence-based practice. And one of my strongest interests is the implementation role or process as part of the whole evidence-based practice process. And I'm going to speak about that today and talk with you all and give you hopefully some tools. And that's what I'm calling this, is implementation toolkit required. And as you, if in case you're wondering, what it looks like we have in terms of participants is we have a number of them that are I can't see that roll. There it is. About 17% clinical specialists. We have about 11% administrative folks. We have about a number of point of care clinicians, advanced practice clinicians, and then quality specialists. We have PTO, RT, speech therapists, and then a number of faculty, and then others. So welcome to all of you. It looks like in terms of years of experience that we have the lion's share of you have greater than 10 years of experience, and then a smaller number under 2 years. So welcome to all of you. I appreciate you being here with us, and I'm looking forward to sharing these slides with you and hopefully some tools that will help you in your implementation step of evidence-based practice. So I'm going to move forward. And I'm going to start with just review with you these 4 objectives I hope to accomplish, is really speak to the implementation phase or step of the EBP process, review some of the theories and models that have emerged to guide evidence-based practice and quality improvement. I want to discuss the importance of aligning implementation strategies with the phase of the change process, or wherever you are in an evidence-based practice initiative, that you align your implementation strategies with that phase. And then I'll introduce and hopefully leave you with some tools that you can use for your own organizations and practices in terms of expediting this whole implementation process. I'll say a little bit more about that and why this is important in a few minutes. Before we jump into some of the slides and the content, I want to introduce you to a tool we've recently developed. It's called the Evidence-Based Practice Implementation Strategies Self-Efficacy Scale. And I'm going to ask you to take a few minutes to complete the scale, which is a really nice thing for us to do. And then at the end, as we conclude my remarks today, I will share with you what the general findings are from this particular group. And there's already over 85 people on. So you can see the link in the slide there. We've also put for you in the notes link the actual scale so that you can have it available to yourself later. And what I'm going to ask you to do for right now, though, is just take a few minutes, and then I will share with you later what our findings are. And I just want to point out in the slide that you see right now that the way this works is all the scores are added together and divided by the 29, which is the number of overall items. And then what we really want to do is just look at how people overall score, and then what are the highest and lowest ratings in terms of specific items. So the next few slides, excuse me, just show the actual scale, but you have it in the link, and I'm going to go back to that slide so that you can actually use the link if you wish. So I'm just going to give you 2 minutes to complete this. It shouldn't take you very long, and you're going to use the scale of 1 to 100 in terms of how confident or what your self-efficacy is for each of those items that are related to implementation.
Hi everyone, this is Bindu. Please go ahead and use the scale survey link in the web links pod. When you click on it, it'll allow you to browse to the survey.
Hey everyone, thank you so much for taking a few minutes to just kind of do your own self-assessment, and then we'll share again how everyone looks at the end, and maybe give you some ideas of where we all can put some emphasis in terms of trying to enhance our implementation strategies. So what is implementation as it relates to evidence-based practice? Well, I like to think of it as a series of action steps that we can put in practice to affect the decisions we've made to change or to bring an evidence-based practice to our settings. So it's really just that series of actions that actually help us get the decision to change moved forward. Implementation of evidence-based practice is regarded as a core competence to improve healthcare quality, and that's among all of us as clinicians, all the way from physicians to our therapy roles, to our nurses, to nutrition, whatever your role might be, including administrators, I might add, who also do evidence-based administrative decision-making. And then lastly, I would say that implementation is the hardest step of the evidence-based practice process in terms of actually initiating change and making the change stick. When we think about evidence-based practice, there was a study done in 2013 by Weng et al. Around implementation and across the disciplines that I just mentioned a few moments ago. And what's interesting is they investigated the sort of practices one will self-report among these professions, as you see, physicians, nurses, pharmacists, PT technicians, and then other. And there were over 6,100 participants in this particular survey. And I just put this slide up from the paper, which you can see at the bottom if you're interested in getting it. But where you see a lot of white space is basically, or the white color, is that they do none. And sadly, nurses are among, and technicians are the ones that reported they do no evidence-based practice on a regular basis. Whereas our physician groups tended to report more frequently, especially in the daily, weekly approaches and monthly. But it is concerning that this is even self-reported data that I don't use evidence-based practice in my routine practices. Now, implementation and translation have their own unique definitions, which I will talk about shortly. And many people use these words interchangeably, and to some extent I use implementation and translation in that regard. But I wanted to say a little bit about how they look clinically compared to implementation science, the science behind it. So implementation science emerged, I don't know, a couple of decades ago, where it really grew, and it's the methods of study that help us look at how to do this, how to promote that systematic uptake of what we learn through research and other evidence-based practice initiatives, to get it into routine practice, to ultimately improve quality and safety and the effectiveness of healthcare services, and have optimal patient outcomes. So it's really that study of what methods will help expedite that entire process. It's a research field of its own. And where and why did this emerge? Well, it was born out of a desire to address the significant challenges we were seeing in the use of research to improve practice in a consistent way. And there are multiple gaps that are cited. I'm going to show you an example of that shortly. So this need to really establish some theory behind how to improve this and how to get it happening on a regular basis, and what strategies work under what conditions for what types of practice changes, is something we continue to try to discover and understand better. As you can see in this slide, this is a sort of a picture of the research to practice gap. You can think about it in this figure. And at the wide end, we start out with priorities being identified for research. It might be basic research that begins. These are research projects that have a lot of rigor. They're identified through peer-reviewed processes. And this moves along the ladder of getting what these studies initially learn to becoming published, and then for multiple studies to become reviewed under a research synthesis approach, leading to the guideline development and finally into routine practices. And the sad thing is that whole pipeline takes about 17 years, and that was a publication from 2000. I have read a paper in Critical Care, and there are a few others that are working hard to narrow this gap, but it's still cited regularly that there's this huge process, and you can see why the gap occurs. By the time we get stuff routinely reported in the literature and synthesized as multiple studies that can say this is a best practice, years go by. And then the sadder part about it is the statistic that often people don't realize is that this happens where it actually gets to practice in routine ways for about 14% of evidence-based approaches, or 14% of interventions studied through research. So that means the lion's share of what we do never gets to practice. And that is something that has really led the whole implementation science movement. And just to, by example, for myself as a nurse and for those of you that work in healthcare, hospital settings, I'm just showing you a few examples. Hand washing. And we know hand washing is important for preventing the spread of infection and preventing the spread of hospital-acquired infections. And yet we've had to have enormous initiatives with regulation and with monitoring put in place to have compliance with hand hygiene reach that 90% and above. And hospitals and ambulatory settings continue to cite problems in this regard. So this is one example. And there are multiple reasons for that, but nevertheless, it's an example and a classic example where we fall short. Another one that we've ultimately changed over time due to regulation and mandatory at least declination is flu vaccinations. And flu vaccination for healthcare workers is really a patient safety issue. If you are unaware of it, there are probably 35,000 plus people that die in hospitals of influenza infections every year. And so it's imperative that we do everything we can as hospital clinicians to prevent patients from getting influenza in the hospital. And the best way to do that is to use strategies like vaccinations. And now we at least expect healthcare workers to report why they're not going to get it if they're not. Another one you see with the little mannequin, baby mannequin, is the auscultation for evidence of NG tube placement accuracy. Really, the only way to do that, and many of you already know this, is through radiographic assessment. But we still even teach this in some of our textbooks, that you can auscultate and have confirmation that you're indeed in the stomach area. Fall risk, and fall is multi-component in terms of strategies that are needed. It's also multifactorial in terms of barriers and things that actually contribute to falls. Yet there are great examples of inconsistencies in implementing bundles that we believe work, even though there's inconsistency in that. And then lastly, I point out CLABSI and CAUTI, which are two of the hospital-acquired infections that many of you are aware of, the bloodstream infections from catheters and or central lines, and then the catheter urinary tract infections from catheters. So one of the things that I think mixes people up a lot is this whole terminology challenge. And if you think about implementation, it really is part of a diffusion, dissemination, implementation continuum. And you can think about diffusion as being sort of that passive, kind of an untargeted dissemination approach, or unplanned spread of new practice. So we get new information and we sort of passively spread it out, but it's not targeted and it's not structured. When we move into the dissemination approach, we start to actively spread it with new practices to a targeted audience using scheduled and structured practices that we know are effective in helping the rollout of a new or well-studied intervention. And then moving into implementation, that's that process of putting to use or integrating new practices within a setting. So when you think about diffusion as kind of the passive approach, dissemination is wider spread but targeted, and then you get to your own settings where you're really looking at implementation. And those are not necessarily scientific terms. Those are the terms we use for differentiating those different sorts of phases on the continuum. Just a little cartoon for you in terms of just kind of illustrating the problems we see with knowledge being utilized. And it's just essentially, you go to a great training, you go to a 5-day immersion, you get really excited about a project that you led or an initiative, you come back and you lose the momentum because of all the barriers. And so that training is already forgotten, the binder lasts forever. And it just illustrates that this is not a new problem. It's been around in many cases when we're trying to initiate change and in many industries. So what is translation? It's a process of turning observations into laboratory clinical, that are discovered, in laboratory clinical and communities into interventions that can improve the public health of our individuals. And it can be anywhere from diagnostics, therapeutics, all the way to medical procedures and behavior changes, which in nursing, we do quite a few studies around. I already mentioned how it moves into the scientific world, but just to say this field of investigation focuses on how to expedite that entire process of bringing interventions to our patients and to improve public health. This is a diagram from the National Institutes of Health, and it just shows that it's sort of this circular strategy that we start with in the purple circle, the basic research. We hopefully lead into, and this could be at the cellular level in the lab, and then it can go into preclinical, which can include some animal models, oftentimes, especially with any kind of an intervention that poses any harm to patients. And then it moves into some clinical research trials and hopefully into the patient clinical environment, and then ultimately improving public health for everyone. And all around, all of what's in the center is the idea of patient involvement. And that's grown over the last 20 years of really engaging the patient from the inception of an idea all the way through the final stages of getting it routinely into practice. I'm going to shift a little to talking about theories, models, and frameworks in implementation science. And I like this paper by Nilsson in 2015, where he really does do a nice job of making sense of the different approaches, and he thinks about them from sort of a high level umbrella, if you will, as theoretical approaches, and then sort of distilling down a little to thinking about them as descriptive approaches, guiding approaches, to understanding and explaining what influences outcomes, and then to evaluating. And then under each of those, or in particular the middle one, you see determinant frameworks, classic theories, and implementation theories. Under the evaluating implementation box there, you see frameworks that are really geared to evaluation, and then on the other end you see process models. So let me just give you a couple of examples of these. So I think about the Iowa model, and I came from Iowa, so I was privileged to be a part of the evolution of this model over time. It's well known, and it is well used across the world. But you can think about this as just definitely an application-oriented approach to bringing practice changes to patients. And it goes through sort of a step-by-step approach. So I would call that a practice model. When we think about determinants frameworks, I think about the Paris framework, which is promoting action on research implementation in health services. This model is also, or this framework is also well recognized and used worldwide. I have appreciated the framework myself and used it to guide some of the work that I've done. And I like that it really does have those three core components of what does the evidence say, what kind of climate and organizational culture is this practice being brought to, and then who or what is going to facilitate. And that those three things together can lead to the successful implementation of an evidence-based practice initiative. And then you see in the box, of course, the evidence, facilitation, and context, and under each of those, what elements make up that particular component. I also think of another Iowa model, this or Iowa product, if you will, as a determinants framework, is the evidence-based practice and action implementation guide that Laura Cullen and Susan Adams developed. And I'm going to speak more about this because we used the elements in this, all the strategies that they identified in the development of our scale that you all just completed. And we've also used I've used a number of these strategies, or our team has, to think about how we can improve and expedite this process of evidence-based practice. I'm going to point to a book that evolved from this as well. That's just a resource FYI for you as I conclude this presentation. Another determinants framework that you'll see in the literature is by Feldstein and Glasgow, and this is called a practical, robust implementation and sustainability model, PRISM, for integrating research findings into practice. And what's nice about this is, as I mentioned a moment ago about the importance of the patient perspective, I like that from the beginning, the onset and development of intervention, they think about the organizational perspective, but also the patient perspective as helping to actually design the intervention. This moves then into, in that sort of structure and sustainability implementation landscape, along with the external environment, then the intervention is tested out. Who's going to get it? And that is going to also help design and test the intervention. And again, patients are a part of that, as are leaders, managers, and staff. So those are the recipients of the intervention once it's been developed. And then also you see that that moves further into adoption, implementation, and maintenance, along with which really constitute that research reach and effectiveness. So that's another determinants model. Then, as Nilsson identified in his paper, there's also classic theories like the law of diffusion of innovation, which is Everett Rogers' model. And this grew out of agriculture, and actually Everett Rogers was in Iowa as well. But what's nice about his model and how it's been used really ubiquitously across the world in many academic disciplines and outside of healthcare as well is this notion that there's a tipping point of once you bring in an innovation and you've got upwards of 15% of people involved, you've got your innovators and the early adopters, you're moving into getting that sort of majority, that sort of the normal part of the distribution. You're starting to get to the tipping point of what brings about change. And that's where you can really see some momentum and where you can start to really emphasize and reinforce those implementation strategies. And Rogers put forward the sort of similar steps as many have done, is it starts with knowledge moving into persuasion, decision, implementation, and confirmation. And then I also wanted to highlight Russ Glasgow's model. This was developed in 1999, and I got another model that is, or framework they call it, is that's well known, well used, and guides many grants that are being submitted to NIH that are implementation style grants. But this is an evaluation framework, and it uses the REAIM approach. You think about reach, and you can do this as you're designing an intervention. You can also do it post-hoc when you're trying to evaluate an intervention. But so how do I reach the targeted population? Did I reach the targeted population? How do I know that the intervention is effective or was? How do I develop the institutional support? How did the institutional support impact the initiative? Into how do I ensure the intervention is delivered consistently and properly with fidelity? And then how do I incorporate the intervention so it stays active and sustained over a long period of time? One of my colleagues recently shared this paper that was just published by Lee, Jeff, Sparwicks, and Stevens, who generated the systematic review looking at what are the most commonly reported organizational contextual factors that influence the implementation of EBP across healthcare settings. And they really want to describe how these factors might be affecting implementation. Now, these are not going to be a surprise to you. They looked at studies from 2005 to 2017. They used the mixed methods appraisal tool, ultimately looked at 36 studies, 20 being qualitative, 11 quantitative, and 5 mixed methods. They identified 6 factors, and these are not new. They're not going to be new to you, and they're going to be consistent with what you probably know about change and about what you know about implementation, since many of you are already actively engaged in implementation. And they identified that these 6 factors should not be perceived as being independent, that they're interrelated and they influence each other and they work together. And so when you're developing an implementation plan for your evidence-based practice initiative, you want to be mindful of what's your culture? Do you have a culture of change? And I'm going to suggest a couple of tools for you that can help you look at your organization and what its readiness is for change as well. Who are your leaders? What is their perspective of the whole process of change, as well as evidence-based practice being a mission statement and driving your healthcare or whatever arena you're in? Networks and communication. Do you have those in place? Those are critical, and I'll give you an example of that as we go through and look at our findings, which I suspect we'll see from all of your responses what might be one of the lowest confidence implementation strategies. Resources, of course, whenever you're generating a practice change, you're going to need human resources as well as probably a number of other resources to actually execute the approach. And you're going to need them from a sustainability perspective too, to ongoing monitor the fidelity of the practice change and also outcomes. And then finally, champions. So champions are also mentors. They can be facilitators, like in the Paris model, in the model we use, the ARC model at Ohio State, which Dr. Melnick and colleagues developed. Champions and mentors we call them mentors here, are seriously a critical part of the successful implementation of an evidence-based practice change and the sustainability. The other model that I want to mention, which the authors that just published this paper highlight as being really consistent with their findings, is Laura Damschroeder and colleagues published this in 2009, and it's the Consolidated Framework for Implementation Research. And this one is also growing in terms of recognition as a really appropriate framework for guiding implementation. And you can see that it has some of these same categories that the research systematic review found, and they are characteristics of the intervention, how strong the evidence is, what the quality of the evidence is, what are the advantages of it, adaptability, triability, and that stuff comes out of Everett Rogers' innovation framework. And then it goes into looking at your inner setting, structure, networks, culture, implementation climate, into the outer setting, what are the patient's needs and resources, what is the peer pressure, the external policies and incentives, cosmopolitanism, and then the individuals involved, and that's going to include us as healthcare providers and the characteristics that are going to be important when you think about their involvement in change, and then the whole process of planning, engaging, executing, reflecting, and evaluating. So I want to shift here now to just maybe bringing you to some tools so I leave some time for questions. The tool you all participated in terms of self-efficacy around a number of strategies, we developed that from different tools in the literature. So we had some face validity, and then we also did some content validity on it using an index available for relevancy. But we drew them out of, so for example, this study was published in 2003, and they did a nice review of strategies used for implementation and what the evidence was. And you can see that probably the most effective types of strategies are interactive small group meetings. Opinion leaders got mixed reviews, as did educational strategies. But then you see reminders, decision support from computers, introduction of computers into practice, all had moderate to good effectiveness. And then we also see it for multi-professional collaboration. We also see it for mass media campaigns. And then we see it for combined interventions. And these just remind us of the most robust strategies. And there's been some additional work since then, including Byron Powell and colleagues. Byron's from University of North Carolina. They published this nice approach in 2015 where they used a Delphi approach and built an expert panel. And they looked to refine a published compilation of implementation strategy terms and definitions by looking at stakeholders and what their expertise would suggest are the most important clinical and science strategies. And so they had 73 implementation strategies in their final analysis, and they went back and forth on this and really employed that Delphi technique. And this is just an example. They alphabetized their strategies, and they have a definition. Now, they did not isolate the research around each of them. That's probably an next strategy for them. But these were identified by leading experts in the world of implementation. And here's another page of them. But you can find for yourself in this paper what other strategies are, since I didn't list them all. But we used, so the paper from 2003, we used this list of strategies, and then we used Cullen and Adams' list of strategies to develop the tool that you completed today. And we really wanted to sort of consolidate to make them as, narrowed as we possibly could so they got at detail, but also had to make this scale usable in terms of being able to get a sense of what knowledge or what confidence one has in even executing any of them. But you could use all of the strategies available to you in your own toolkits and building a cadre of those that you seem to find are most effective in your organization. This shows the top half of Cullen and Adams' approach, and they think about this as many people do, following phases, identifying, beginning with creating awareness, to moving toward building knowledge and commitment, and to promoting action and adoption, and then pursuing integration and sustained use. And what's nice in this particular approach is the top half are the clinicians, organizational leaders, and key stakeholders. So if you're wanting to create awareness with that particular group, you might begin with highlighting advantages and the anticipated impact. You might go into journal clubs, staff meetings, unit newsletters, just different strategies that can help get a practice change in front of clinicians to start the awareness process. And then as you move to building commitment and knowledge, you're going to engage some of these additional strategies, maybe education, pocket guides, linking practice change and power holder stakeholder priorities, maybe building your mentors then and your change agents. Then as you move into adoption and action, you're going to add maybe skill competence, giving evaluation results to colleagues, incentives, trying to practice change, elevator speeches. And then finally, when you start to see the sustainability and you want to maintain it, you're going to look at celebrating unit successes, individual feedback, which is a very powerful strategy. That's auditing and real-time feedback, personalizing messages, using peers as influencers, and continuous reminders. And then if you look at the lower half of their particular approach or framework, they think about the organizational system support that also has to be at each of these 4 phases. And you can see on this slide what those will include. So I'm not going to, in the interest of time, spend a lot of time going over those. I'm going to show you a couple of examples anyway. So this is out of their paper. This is for 2 previous studies that were published, and I think are really illustrative of how this works. So let's say that you wanted to introduce screening for preoperatively for sleep apnea because that poses a risk for patients undergoing anesthesia. And the evidence says we should be doing this. So you may start by creating awareness using this is a reason for doing it. You may hold staff meetings. You may use in-services, and you may use postings, just by example of strategies to build awareness. Then when you start building knowledge and commitment, you're going to go into some of these others, case studies, teamwork, champions, integrating with other policies, but you're going to bring all those along to help deliver this intervention, which is about screening preoperatively related to sleep apnea. And then as you move into action and adoption, you'll think about different strategies like clinical reminders, developing workflow and demonstrating it, feedback again, trying the change, and as you see, rounding by unit leaders and other strategies. And then finally, when you pursue integration and sustained use, you might use recognitions, update reminders, quality improvement reports with trending results, etc. And by another example, identified as an important evidence-based approach is in the emergency department using regulation for adult trauma patients. And here, creating awareness and interest might be highlighting the advantages and anticipated impact. You might use staff meetings, unit services, postings. Then you go into building knowledge and a commitment to this change of thermoregulation for adult trauma patients through education, change agents, gap assessments, clinician input. Certainly that's an important part, teamwork, etc. And then promoting action and adoption. So now we're going to get this practice routinely into an approach that we believe in because the evidence is strong and that we want to be a part of our practices. And you'll use any number of those strategies, reporting the program, change agents, incentives, skill competency, role modeling. And then finally, when you get into the pursuit of integration and sustained use, you can use peer influence, personalizing it, presenting it in educational programs, etc. So that's just 2 examples of showing you how thinking about an evidence-based practice initiative, you've done all the work up front with identifying the problem or the change that you want to make. You put it into a PICO question. You've developed your team to look at the research literature, and you've got well-established search terms, and then you have a well-established protocol for reviewing the literature. And so now you've got a sense of what is the best evidence suggests needs to happen. And then that's where you need to start moving into creating awareness, building knowledge, promoting action, and pursuing integration using this model. There are many models you can use that I've showed you an example of today, all of which, again, get at, we know what we need to do. Now, here's how we got to get it into practice. Now, I can't show you this because it doesn't work well to show a video on our webinars, but I want you to see this, if you have not already seen this, as a great example of what happens when you add strategies that get at the phases of change, whether it's awareness, knowledge, integration, or sustainability. So this is a really good video clip of children around hand washing. And what it shows you, I'll show you in the next slide, is that when you combine at least 4 or more sources of influence, you really start to pick up the momentum towards change. If you only use one strategy and one little source of influence, you're unlikely to lead to sustainable change. So I encourage you to watch this video. It's funny, it's cute, and it really illustrates very simply how these things work together with kids. And it will work in your place as well in many different practice arenas, as well as whatever practice change you're trying to accomplish. And these are the sources of influence. So, there's 6 of them here. They're along the dimensions of motivation and ability, and also along the rows of structure, social, and personal. So, for example, under motivation and personal, make the undesirable desirable. Do they want to engage in the behavior, you'll ask, and how can you improve that desirability? If you're moving on the other side around ability and it's personal, do they have the right skills and strengths to do the right thing? And so what you want to do there is help them surpass their limits, provide what they need to move in that direction. And the same thing, you can ask questions under the social, under the structural, and under motivation and ability. So this is another great resource. This is from Grenny and colleagues. Their 2nd edition, I think it was, I can't remember the exact year, sorry, I missed that on here, but it's from New York, McGraw-Hill, and it's called The Influencer. Excellent book for understanding how to be an influencer and influence change in your organization. So I mentioned a couple of other tools. These include organizational readiness, and this particular tool has this slide and then the other slide. And this is putting evidence into action. And I like this particular tool because it shows you what are the capacities and resources. Do we have them? We do not have them presently, but can we build it? No, we don't have this capacity, and then some comments. And it's just meant to be a tool in your kit to help you think about an evidence-based practice change you want to make. What do you need to think about from a staffing perspective, a training perspective, a recruitment perspective, an adaptation perspective, and then also implementation and maintenance. Going along nicely with all the things I've been talking about so far around thinking about implementation along a phased approach and what it takes in terms of multiple strategies and influence sources to bring about change. I also bring your attention to this context assessment index that McCormick and colleagues published in Worldviews on Evidence-Based Nursing, that journal, in 2009, and they used the Paris model. And this framework shows the successful implementation of evidence in practice, again, as the interrelationship of the quality of the evidence, the context of the evidence being introduced, and the expert facilitation. So they use that model to guide the development of this context assessment tool that allows you to evaluate your context and readiness, if you will, for bringing about an evidence-based practice initiative. It's a little bit more granular in terms of specific items, and you can use it to get a total score as well as the subscale scores that they have in it. And you can also use it to kind of think about the items and how they relate to your organization and its readiness. And the items they identify, I put for you in this table that I pulled right out of the paper. So this is published in the article, which you can get yourself. But it has 37 items, and they've got good validity and reliability on this scale. And it really gets at a number of dimensions around evidence-based practice and implementation and the kinds of strategies that will help make your organization most successful and really work to have a culture of evidence-based practice where it actually is implemented in a regular way. So Bindu, let's go ahead and put up our results. Let's see how this group overall responded. And then that will allow us time for some questions and answers, hopefully. So Bindu's going to put up our total score, and then she's also going to just show us how we scored as a group in terms of items that we were most confident in, down to items that we were least confident in. And I think I'm really eager to see if the items that you were least confident in, or the item that you were least confident in, consistent with what we found in a couple of other projects. So the scale we tested initially through, we used a system of looking at face and content validity, and then we moved forward with testing it with a group of nurses here in Ohio, at Ohio State at one of our medical center locations. And we had good reliability with it. We also, in terms of internal consistency, and we also found it correlated with all of the subscales in the context assessment tool that I just reviewed with you and in the direction that we'd expect. So we've got some preliminary data that say it holds up, and we'll continue to look at it and evolve it as it meets the needs of our practitioners and helps and possibly helps improve implementation. So we had 47 people complete the scale, and we have almost 100 people on, so about half of you were able to get it done. We had a total score of about 69.87. That's really interesting. And the standard deviation of 17%. That's almost identical to what we found last week in a webinar. And it's pretty close to what I found with the people that completed a study for us. And so the answers ranged from 35, approximately 35 to 96. And that's actually very close to what we found before too. So whenever you're ready, Bindu, if you want to go ahead and So basically what those answers say is that overall, there was confidence around 68% that I felt about that from 0 to 100% confident in using that scale, that there was about 68% average confidence for those items. So some of the items were lower, some of the items were higher. So here's what we can see. And oh my gosh, this is more consistency. So item number 10 has been the lowest item in all three of these groups that we've assessed so far. So you can see mobilizing needed electronic health record and electronic medical record changes to facilitate implementation of evidence-based practice is always rated the lowest in the groups we've done so far. And what's even more intriguing about this is we're leading another study here with Dr. Esther Chips as our lead primary or principal investigator, and a number of us are on this project, and we're doing focus groups across the country using web-based approaches. It's working really beautifully too. But we've done a number of focus groups. We're done with them now, asking them how their electronic health records are working to facilitate evidence-based practice. And what we learned was there's lots of issues, ubiquitously lots of issues, and huge delays in getting the EMR to be a resource for moving evidence-based practice forward. And we know that is an important strategy. So indeed, that is our lowest one again. What else was low? Obtaining needed human resources, engaging patients and families. And that's an important one because that's actually part of the evidence-based practice triangle. When you think about what evidence-based practice is, it's the evidence, it's patients, families, values and preferences, and it's the clinician expertise and experiences they bring to the process. And so we have work that we can do in engaging families and how to adhere to an evidence-based practice initiative. And then so you can see for yourself, I'm going to go up and look at the top three now. And the top three, the top one was developing a staff educational plan. And that doesn't surprise me. It probably doesn't surprise any of you either, because education seems to be the one strategy we roll out most of the time. And we're really good at it, actually. Unfortunately, education by itself is insufficient, and we have multiple examples of that. If education were sufficient, we probably would, many of us, be out of healthcare jobs because our patients would be taking the education we give them in a pamphlet and making the appropriate behavior change they need. So it just doesn't work that way. There's lots of complexity. Using creative strategies, that's really nice to see. Pocket guides, flyers were our example in this tool, but to promote implementation, that's really nice to see. Piloting the practice change or testing out the practice change, or I think there's another word we've been talking about, because pilot we don't want to mix up with research. It's just meant to test it out on your unit and see if it works before widespread occurrence. And then using informal leaders, experts, we love to see that. That highlights that people are using not only mentors, but informal unit leaders, people with strong voices. And then I see that the mentors, using mentors and facilitators, number 15 was also in the 70s. So this is useful to us, and I'm going to wrap up here and just encourage you. We made that available to you. It's in the folder. And we also, if you want to share anything with us and improve this, or just help us think about how to make this kind of an approach more available to people to help them improve their evidence-based practice approaches, we would love to learn from you. So I'm going to stop there, and I'm going to let Brian kind of lead the Q&A session. Is that right, Brian?
Yeah, so if you folks would just type your questions into the chat box, and then we will answer them one by one. And this will just make it nice and smooth for us. In 1 second here. So a question I see is, can we use the scales shared today in our organizations to help us with EBP?
Absolutely. I certainly welcome you to use that scale, and I would love to learn from you, though. So, I mean, I think we all would. So if you could share that with us, we would love that in terms of the implementation strategy self-efficacy scale. I have another self-efficacy scale. It's just the evidence-based practice self-efficacy scale. If you're interested in that, I'll refer you to the website. You can request it and get it immediately. This one just looks more broadly at what is the competence level of your staff in terms of understanding evidence-based practice. And you can use that. It's used worldwide now. We have a number of scales here at OSU as well that I know our team here would welcome making available to you. In addition to the one I showed you, the ones I showed you in this presentation, both the organizational readiness assessment and the other one that is the context assessment, you are welcome to use those. They're publicly in the literature and available to you to use. So I'm not giving you permission. We want to make these tools available in any way that we can. You're welcome. How can we make these slides available?
So we'll send these out. I think they go up on the, we'll put them in the email that we send out to everybody. We'll make sure that we have a link available for that.
Yep, we'll get those available to you. Good question. Oh, I like that. Is that LGF? Is that my LGF? Great idea, Lynn. I like that. I knew there was some other sort of language, so we might tweak that a little to stay instead of pilot, use incremental rollout. Good job. I like that. Get us away from that researchy term. Other questions? Great job. Thank you so much. You're most welcome, and I appreciate so many of you being online. There must be a few more questions. Anybody want to challenge me on anything? Dr. Melnick, are you on? I see her name there. How do you overcome the late adopters to EBP? Great question. And I guess my perspective would be, and there's many people that have written about this as well, I think it makes sense to just focus on really leveraging your early adopters for starters. Obviously your innovators, but your early adopters, and then really look for your informal leaders to move along the middle group and the vast majority of your staff and who's ever included on your teams. And then ultimately, the people that are the real laggards, they either come along, begrudgingly and accept that this is a practice change that has to happen, or I do believe, my personal opinion as a leader, it would be that, you got to pull them aside and have a crucial conversation with them. Once a practice change is being implemented and really embraced by the vast majority of people, you got to expect some other people that they're just going to have to come along. And if they want to sabotage it, that's a crucial conversation in my mind. But I totally agree that you can have some informal people bring some challenge, and I've dealt with that myself. So great question.
Here's another question, Sharon. Can you give some examples of personal motivators for staff to implementing EBP initiatives?
Yeah, absolutely. I mean, I personally think some personal motivators could be like a clinical ladder. If you have a clinical ladder, strategies that can raise people's interest in doing the right thing. Are they going back to school? Can you involve them and embrace a project they need to do for school? Can you celebrate their successes publicly? Can you engage them in a publication? Can you have a celebration with the entire team? Can you ask them to lead an initiative? And by the way, that's a great way to get at your naysayers too, is to maybe pull them along and embrace them and their skills and strengths and ask them to actually even help co-lead a project. Let me think. Anyone else can write in if they have another suggestion. Those are the things I think about mostly, but tying it in even to your performance appraisal. We did that when I was at Iowa. We built it into the performance appraisal and your expected job competencies. See here, and I'm going to read some of these. Dr. Melnick said, don't forget how important it is to share stories that raise people's emotions. Great one. Thank you, Bern. So whenever we have the opportunity to connect with people on an emotional level as well as a cognitive level, we're likely to enlist their interest in change. So that is a great one. One person says our organization is changing to the DMAIC and AP3 approach. I know both of those. I think the DMAIC model, we used a little bit of that one, or we did when I was at Iowa, actually, and when I was at Mayo. And essentially, you just have to tie it into defining. When you begin with the define, I would bring along, here's what the research evidence says. When you're building the implementation strategies, the things that you want to actually change, just pull the evidence along, and then you're going to pull along these strategies to help bring about the change. And there's an expectation of sustainability in the DMAIC model as well. So I would just tie it into that quality improvement approach. And I believe that the strategies you use in implementation are somewhat consistent with those in the quality improvement model, but I think they're broader and bigger. Let me see if I covered, let's see, Dr. Melnick also said, I challenge everyone to ramp up their EBP initiatives with urgency, keep dreaming, discovering, and delivering. Let's see, we also see, I prefer, Lynn says, I prefer to call them initiatives rather than projects. I like that too. Project sounds short-lived, and it's like I got that done and checked off my list, so I agree with her. Initiative sounds more far permanent and far-reaching. Amanda, you said, what's it called? What was the question?
They're talking about a blog that Amanda's putting out there.
Oh, yeah. What is your blog called? Synchronized. Beautiful. Or is it synchronized? Synchronized, it looks like, right? And then Lynn says, Simon Sinek, I love his TED Talk. Don't talk about it. What are you going to do? Talk about why we have to do it. That's what inspires people. Excellent. Excellent. Oh, that was, and then Burns says, a person's beliefs about the value of EBP and having EBP mentors are the two most potent factors. Awesome, in the ARC model. Excellent. And we have a beliefs model scale too, if anyone's interested in learning more about that, that Bern has published, and Lynn with many others as well, several times. All right, I think we're about out of time. Did I miss any questions?
No, we got them all.
Thank you all very much for your attention and your engagement. I really appreciate it, and we look forward to hearing from you again.